Hi, so today we're going to be looking at depression and specifically psychopharmacological treatments of depression. Just thought I'd start off with a little fact that it's recently come out that Australia has the second highest prescription rate of antidepressant medication in the developed world, Iceland being the first. So I just think that's an interesting fact to keep in mind while we're looking at this topic. So, depression is the most common and widespread psychiatric illness. It can have a profound impact on sufferers and can significantly reduce their quality of life. And according to the DSM, the essential feature of major depressive disorder is a period of 2 weeks minimum in which there is either a depressed mood or loss of interest or pleasure in most activities. There's many different types of psychopharmacological treatments for depression. It can be treated with antidepressants, mood stabilizers, even antipsychotics. Today I'm just going to be looking at 4 antidepressants: monoamine oxidase inhibitors, tricyclics, selective serotonin reuptake inhibitors, and serotonin norepinephrine reuptake inhibitors. And lastly, we're going to look at electroconvulsive therapy. So, monoamine oxidase inhibitors, MAOIs were the first effective antidepressant medication to emerge, and the discovery of MAOIs actually had a significant effect on the way that clinical depression was once interpreted, as it emphasized the fact that this was an illness that was a chemical imbalance and that could actually respond to medication. MAOIs work by inhibiting the enzyme monoamine oxidase, which is involved in metabolizing neurotransmitters serotonin, norepinephrine, and dopamine. There's 2 types of MAOIs, so the irreversible MAOIs, which are older, and reversible MAOIs. And it's believed that irreversible MAOIs have the potential to treat treatment-resistant depression and other challenging mood disorders. In terms of efficacy, in studies of patients showing no response to tricyclics, approximately 50% responded to MAOIs, and Ficado and colleagues found a positive association between treatment with MAOIs and remission at discharge in depressed patients in a psychiatric unit in the UK. A prominent concern with MAOIs is the side effects, of increased heart rate and blood pressure when MAOIs are ingested in conjunction with tyramine. So tyramine can be found in foods such as aged cheese, improperly stored meat, banana peels, and tap beer. So due to newer classes of antidepressants being on the market with less safety risks and side effects, MAOIs are no longer a popular form of pharmacological treatment. Tricyclics are another older class of antidepressant drugs. So TCAs work by blocking the transporter proteins that reabsorb serotonin, dopamine, and norepinephrine, which extends the presence of these neurotransmitters in the synaptic cleft. In terms of efficacy, TCAs are thought to be effective in treating severe depression. In a meta-analysis by Anderson and Tomlinson, TCAs were found to have a slight advantage to SSRIs in treating patients who scored high on the Hamilton Depression Rating Scale. TCAs also have some pretty serious side effects, so they block the histamine receptors, acetylcholine receptors, and some sodium channels. The blockage of histamine receptors can cause drowsiness. The blockage of acetylcholine receptors can produce dry mouth and difficulty urinating, and blocking the sodium channel can produce heart irregularities. Also, TCAs can be fatal when taken in an overdose, and this is a factor that definitely needs to be taken into consideration by physicians who are prescribing this medication to patients at risk of suicide. So, selective serotonin reuptake inhibitors, SSRIs, are probably the most well-known class of antidepressants, so Prozac, Zoloft, Luvox. The primary pharmacological action of SSRIs is the inhibition of the uptake of serotonin. SSRIs are generally better tolerated than TCAs. The main side effects of SSRIs include gastrointestinal problems, so nausea, sexual dysfunction, and sleep disturbance. SSRIs have similar efficacy results to TCAs, but with less intense side effects and toxicity concerns. And SSRIs often are also able to treat not only the depression, but certain comorbid illnesses. So, for example, fluvoxamine, which is Luvox, has shown to be highly effective in treating psychotic depression as well as anxiety. Serotonin norepinephrine reuptake inhibitors, SNRIs, are one of the newer classes of antidepressants, and they work by blocking the reuptake of serotonin and norepinephrine. SNRIs have also been proven effective in relieving chronic pain that is independent of depression. So the SNRI milnacipran is used for that. SNRIs appear to affect the neurotransmitter transporters in a slightly different manner. So venlafaxine has a high affinity for the serotonin transporter, but not the norepinephrine transporter, and likely acts more like an SSRI in low doses. Duloxetine has a slightly more balanced affinity, but again, it's more selective towards the serotonin transporter, and milnacipran has the most balanced affinity of the SNRIs. In terms of side effects, SNRIs are pretty well tolerated like SSRIs. Their side effects differ slightly, and that's likely related to the norepinephrine stimulation, so side effects such as dry mouth, sweating, and constipation. Some studies have shown that SNRIs have a slightly higher remission rate in the treatment of depression than SSRIs or placebos. So in this pooled analysis study, patients with major depressive disorder were examined in terms of remission rates. So patients treated with the SNRI venlafaxine had a 45% remission rate, while patients treated with SSRIs had a 35% remission rate, and patients given placebos had a 25% rate. So do antidepressants work? The general belief on the efficacy of antidepressants is that they have little benefit for patients with mild to moderate depression. Antidepressants only seem to show a meaningful advantage over placebos in patients who suffer from severe depression. So because of this, psychotherapy is generally the preferred treatment modality for patients with mild to moderate depression. Research suggests that antidepressants and psychotherapy are generally equal in effectiveness of treating all levels of depression, except under 3 circumstances. So antidepressants work better at treating dysthymia, which is a long-term depressive condition. Antidepressants generally do not benefit patients who have suffered abuse or neglect in early childhood. And psychotherapy tends to produce long-term benefits and decreases the chance of relapse after the course of treatment is over. The last thing we're going to look at is electroconvulsive therapy. So ECT is a form of treatment in which a seizure is induced through an electric shock to the patient's brain. While it's often pictured as cruel and inhumane in the media due to its barbaric uses, the barbaric uses of ECT in the 1950s, nowadays it's quite a safe procedure. Patients are anesthetized and given muscle relaxants to minimize discomfort. And it's regarded by many professionals as life-saving for patients suffering from treatment-resistant depression and strong suicide ideation. ECT can be performed either bilaterally, so shocks to both hemispheres, or unilaterally. Memory impairment is the most concerning side effect of ECT, so patients can experience both retrograde amnesia, impaired memory of what happened prior to the treatment, and anterograde amnesia, impaired memory of events after the treatment. In terms of efficacy, the relapse rate of ECT is quite high, with 30 to 50% of patients relapsing within the first year despite the use of pharmacology follow-up. Continuation ECT, the use of ECT with steadily increasing intervals, has proven an effective way to prevent relapse. In one study, 7% of patients relapsed within 2 years compared to 52% of patients in a drugs-only group. Does ECT work? Yes. ECT can help bring severely depressed and suicidal individuals back into a functioning state when all other treatments have failed. The immediate risk of suicide decreases faster with ECT than drugs or other forms of treatment, and though the side effects of ECT can be extremely unpleasant, patients generally are pretty happy to tolerate the cognitive side effects if it means gaining relief from the painful depression that has otherwise been untreatable. And as previously mentioned, continual ECT helps prevent relapse rates and readmissions into hospital. And so just as a conclusion, there are many different psychopharmacological treatment types for depression. They all have their strengths and weaknesses and are apt at treating particular symptoms and levels of depression. And it's important to remember that just because one medication or treatment type helps one person suffering from depression doesn't mean it will work for all people suffering from depression. So everyone reacts differently to different antidepressants. And this completely undermines the individual's personhood. There are many different treatment types available, and a competent doctor should be willing to explore these fully while taking into consideration the situation and history of the patient. And lastly, when looking at remission rates of antidepressants and ECT, we need to be mindful that there are a myriad of reasons why a patient may have recovered. It could be that they're in therapy, undergoing therapy in conjunction with taking medication. It could be the fact that they're in hospital. It could simply be that time has helped them feel better. So due to this, we need to be wary when interpreting results concerning antidepressant and ECT efficacy. Okay, thank you.